that was quite nice to see. So those are my credentials. I'm trying to establish with you that I'm a credible person to talk to. Let's see if we can move this forward somehow. Where would we? Oh, here we go. So I'm going to quickly talk about a few things. First of all, about Liverpool, which is where I work. I suppose I could do a show of hands to see if anyone's ever been there. Then I want to tell you about my hospital group. And then I want to think about the future. And what I'm trying to do as I do that is give you some sense of how in different cultures and in different phases of the economic cycle and different places where nations are. And in my context, I'm describing the UK as a post-industrial, relatively wealthy post-industrial society. And I'm describing India as a relatively wealthy, but increasingly wealthy industrial society of 1.4 billion people, currently spending 3% of GDP on health, whereas across many developed countries, we'd be talking about 9% of GDP. So health expenditure is likely to increase as a proportion of government spend. And I think India is now the fourth wealthiest country in the world by GDP, having overtaken the United Kingdom, by the way. And I think very soon will overtake Germany. So India, very soon, we can predict confidently, will be, yes, congratulations, and leaving the UK in the dust, by the way. So what I'm really saying is there's a lot of positive things happening here, but there are some risks. So this is a picture of the Liver building in Liverpool. It's quite famous. It's got these birds on the top. The Liver birds are supposed to bring good fortune to the populations of Liverpool. Maybe I could just indulge myself. Has anyone been to Liverpool? No. Okay, that's helpful. It's helpful. Well, Sai has. I know Sai has. So, okay. So what we're talking about here is a city. It was declared as a city back in the 13th century. Okay, so we're talking about a city that's 700 or so years old. Through a lot of its history, was one of the major commerce ports in the world, and even now, actually, it's the second busiest port for imports and exports in the UK. And the Liver building, this is a UNESCO World Heritage Site on the front. Because of its nature, when the UK was going through the Industrial Revolution, and again, we're talking hundreds of years ago now, really, then there were a lot of immigrants from Ireland in particular who were the workforce, who were the labor force of a developing nation. And therefore, there is a strong religious culture in Liverpool between Anglicans, so that would be what we would call Church of England, and then the other big cathedral in the city is the Catholic cathedral, and that reflects, by and large, immigrants from Ireland coming over as a particular labour force. Now, the point I'm going on to here is other religions exist. So in Liverpool, football is a big religion, and this is the stadium for Liverpool Football Club, and this is the new stadium coming up of, maybe it's coming up somewhere. Where's the best place to point? This is the new stadium of Everton Football Club. So they're the two Premier League football clubs in Liverpool. The next slide takes me on to what I think has become something of a religious zeal in the UK, which is about the health service. So in 1948, the National Health Service was formed and was seen as one of the great developments in social healthcare in the world. And the UK, by and large, is very proud of the National Health Service. So this is the old Royal Hospital where I've worked for some years. When I first arrived in Liverpool, I thought this was one of the most awful hospitals I'd ever seen in my life. And I'm happy to tell you we've demolished it and built another one. But my point is, what I'm trying to make is, having showed you the cathedrals and the football clubs, people become very attached to their health services and start to demand of them and expect of them some things that maybe the people who work in them don't really expect. So anyway, we've knocked that one down and we've moved into a brand new hospital. This is the Royal Liverpool. That's got about 400 beds. So compared to GEMS here, where I understand there are 1,000 beds, it's a bit of a tiddler. What we did with this hospital is we made every single room single use with ensuite bathrooms in place. And I want to remind you that in the UK, by and large, healthcare is delivered by the funding is delivered by the government, paid for by general taxation. My experience, by the way, of having lots of lovely single rooms is that if you're poorly, if you need to recover from a surgery or whatever, it's fabulous to have a single room. If you're a frail old lady who's recovered from her chest infection and you're waiting to go home, a single room is a bit of a disaster because it isolates you. You can't move around. So you begin to decondition. And I think that has become a real problem in the UK about our bed occupancy, which in my hospitals is running in the region of 95%. Because they are very much overwhelmed by the caseload. And I think that is something about a post-industrial society that's really struggling now with some other changes. So this is the New Royal, and it's a very nice building, by the way, and has amazing modern theatres. We do a lot of robotic surgery. I think probably in Europe, the American Da Vinci robots made by Intuitive are commonly used, but I've been made well aware of excellent robotic surgery with robots made in India now. And again, I think what we would see is all manner of exports from the Indian subcontinent into Europe of new technology and new techniques, because I think it's entirely accepted. So again, from the industrial base, there's lots of excitement, but the Americans probably got there first. Okay, so we need to be thoughtful about that. What's here, maybe I've got a pointer as well. Oh no, okay, never mind. I'll show that in a bit. On that photo was our hospital, but also a very large pathology lab with, I think we've got our analyzer from Roche is the largest analyzer in Europe. So, you know, we're in that place now, aren't we, where you put your blood sample in the middle at the front of these machines and they churn out extraordinary results in not very long, and they keep the sample and it's there for research and so on. So, I mean, facts-wise, I've driven past your A&E department. We have two A&E departments, one in the Royal I've shown you and one in Aintree. We will see 300 patients a day through each of those A&E departments. It's pretty obvious that from a medical perspective, not all of those patients need to come, but they come to an A&E department as a place of safety. And if other parts of the system are not meeting patient needs, then they will come. So we kind of feel, and sometimes perhaps rather rudely describe those A&E departments as system failure departments, because patients come there because they're not getting their care somewhere else. And so that is a little trigger to be thinking about how systems are structured in now and in the future. Inevitably, healthcare institutions become large employers of people. And certainly in Liverpool, I think our group now is the largest single employer. So as you employ large numbers of people, you have other social responsibilities in terms of looking after your workforce, and therefore inter alia looking after their families. So we're very aware of our social obligations to our workforce and to the community. So one of my themes for everyone is that the purpose of a hospital is much larger than improving outputs for patients. It's around improving the lives of the people who work in the organization, being a good employer. It's about being socially responsible. It's about procuring services locally. It's about developing a research and innovation agenda which brings wealth and innovation into local economies. And I think we're seeing more and more of that theme emerging in the UK now, and a recognition which will be matched across the rest of Europe, that engaging outside of the country in a system which is about global health is an important thing to do. Health, I think it's easy to argue, is a global industry, and therefore being thoughtful about how we understand how other organizations are functioning, how we move people around the world, how we get experience in other places is an important and legitimate part of that endeavor. Our annual turnover is probably more than 1.4 billion now. So that's a lot of cash. I have no idea, forgive me, what that is in rupees, but it's probably 1.8 billion US dollars. If you look at hospitals in the UK, 70% of the cost is staff, 10% is drugs, 20% is the rest. Okay, now I believe that staff costs in India are much lower than in the UK. So that pressure is a bit different. I'm certain that drug costs are lower than in the UK. So there are certain structural advantages that you have in India, which are really important and helpful and useful to use. But I beg to suggest, be careful, because almost certainly labour costs will rise over time, and maybe the drug costs will too, let's see, and the technology costs. But you can see, depends where you are in the world, the pressures on your budget may be substantially different. And we serve a population a little bit the same, 2.8 million people across the county where we're based, which is Cheshire and Merseyside. So just to, I mean, this is nothing more than give you a flavour about how we run our business. And I've not been at GEMS long enough to know how you run your business. But inevitably, we have a lot of regulators, as I know you do, and I know the School of Medicine has regulators. So you have to answer the exam questions on behalf of the regulators and prove that you're a competent and well-organised organisation. And we do that through these sort of dashboards of improvement methodology. Most developed trusts in the UK will use a particular improvement science methodology. Often they've come from industry, from Toyota, for example, and it's a pretty common approach to use those kind of methodologies to develop behavior and then have these kind of dashboards. Now, let me be clear, and there might be some of you in the room going, how old-fashioned to use red, amber, and green as some form of improvement methodology. And I agree, the evidence for RAG ratings in terms of improvement is very, very weak. But sitting behind these colors are a series of run charts or statistical performance charts, which give us the justification to then summarize. And to be candid with you, when we are showing this sort of information to our board or maybe to the public, it's easily understood. These red, amber, green charts are easily understood, but the methodology of RAG charts is very, very weak indeed. So this is a presentational thing, and if you really want to get into improvement, you need to have statistical run charts running behind them, which we do, and I'm sure you do too. So very quickly, these are the hospitals in our group. Aintree is a major trauma centre. Liverpool Women's, we have 7,000 births a year, so it's the single largest maternity unit in England. We have a caesarean section rate of nearly 50% now in that hospital. When I've talked to colleagues in Delhi, I've been aware of much, much lower caesarean section rates. So we're definitely not proud of that caesarean section rate, but that is a function of society changing. Also, frankly, more comorbidities, older women giving birth, more comorbidities, patient choice, and so on. But when I was at medical school some years ago, thank you for the introduction about that, the caesarean section rate was 20%, and I think that's pretty much what it is in India. So don't be surprised, that's all I'm saying, if you see your caesarean section rate start to rise. Liverpool Heart and Chest is a specialist heart and chest hospital. We've moved some elective surgery away from the busy acute hospitals in order that our surgery programs are not overwhelmed by emergency patients coming in through our departments. And then the building at the bottom right is our big pathology department. And we've moved most of pathology out of our base hospital sites, so that we can have really big analyzers that are processing the work. I think that theme of sort of centralizing quite a lot of, if you like, high-end pathology into big analyzers makes economic sense for us. And as a consequence, we do a lot of business, and it is business in a sense, for both general practices across the county and also for private facilities as well. So, as it turns out, if you have shiny, modern pathology services, it's very easy to build biobanks and to keep samples and therefore drive a research agenda, which is, as I've said before, of all sorts of benefits to the system. So that's been a really good investment. But perhaps I'm coming to something else which I think is quite concerning, which is that despite all our shiny equipment and facilities, in the UK, life expectancy is not improving. Now, any of you who've studied or are studying public and population health will know that the impact of health services in terms of overall longevity and population outputs is not particularly striking. In the US, they think the impact is maybe 20%. And I think what we're seeing is that come home to roost. So we spend a lot of the UK's taxpayers' money on health services, but our shiny hospitals are not leading to huge improvements in health. I think they have great outcomes for surgical and medical interventions, but we end up talking about something different. And in the UK, therefore, the theme very much is about how do you upstream? How do we keep our hospital seeing the patients that are hospitals that it really needs to see, for which it has the expertise and the specialism, whilst other patients whose needs are less are managed somewhere else. Now, there are other bits of the system in the UK who do that, but our experience is we can't control them. So very much our philosophy is moving to perhaps we need to control that and therefore vertically integrate services in the UK. It's a big theme. So, so if you look at what is driving these differences in life expectancy, and particularly across social groups, so social deprivation is a big deal in the UK and we're very sensitive about it. You see the list of essentially of preventable, I don't know if this, but yeah, you know, you see the list of preventable diseases, and they are exactly the same list as in India, of course. It's probably the case that our population is older, almost certainly fatter. Some of them have smoked quite a lot over the years, drink a lot, and those things come home to roost in the end. And hospitals, by and large, don't cure those things. So this is a different discussion about how do we move on to a system which deals with it. And again, just to show you, so we like to put these sort of slides up for our own benefit because they shame us and depress us at the same time. These are statistical issues for Liverpool. So things that are green are good. We're pretty good. We've got very well developed sexual health services, as it turns out, in Liverpool. And I think that's an accident of history, going back to it being a big international port. We are pretty rigorous around antibiotic prescribing, and I'm pretty sure you are too. I've seen a lot of impressive work going on around antimicrobial stewardship, and it's a global issue, so it's very, very important to do it. But I'm afraid you'll see there are a lot of things that for our health economy in Liverpool, we are not good at, and we need to keep working hard at. And these kind of statistical norms are comparing us to other areas of the United Kingdom. So there's plenty for us to do. There's no question about that. And I'm going to show you this in another way. So this is a map of the metro in Liverpool. So this is the railway, in a sense, the tube. And depending on where you are in Liverpool, your life expectancy could be different by as much as 10 years. And that's pretty much entirely due to your status as far as deprivation is concerned. So I think that's pretty shameful in this 5th largest economy in the world, but that is the reality. So in terms of us, from a hospital perspective, that's not really our business per se. If our business is to manage the hospital as well as possible, it's not really our business to be in that space. But I'm saying actually it is our business. It's everybody's business because we need to address those health inequalities. It turns out that addressing health inequalities is a politically tricky thing to do. And the electorate will go along with it up to a point and then find it pretty difficult if they see resources being allocated somewhere else away from their own economies. So I can see why for politicians it's hard to strike that balance, but that is the reality that we're dealing with. So perhaps the good news in a way is that certainly we've got data sets now linked to our own electronic patient records and linked to other electronic records that exist in other parts of the service, and linked to social care records. We've been able to bring all that information together and therefore have a much more detailed understanding of where people live with whatever condition you like. So I think this is just a general map. And the dark colors, of course, are areas where people are experiencing more deprivation. But I've got a similar one. I've been doing some work around respiratory disease in Liverpool. If you map a chronic condition like respiratory, or you take cardiovascular disease and so on, they map exactly to those indices of deprivation. So from a medical perspective, if your purpose in life is to improve outcomes for populations, then the investment, the attention needs to be in this space. So this last summer, we've had a project where our respiratory teams, who are very busy in the winter because we have probably have more seasonal variation in respiratory disease than you have in India. We have a lot of chronic obstructive pulmonary disease in the winter. The teams have been using social data around fuel poverty to go and find the households where there is chronic obstructive pulmonary disease and work with the families, firstly to improve their personal care of COPD. And although COPD might appear to be a relatively straightforward respiratory condition to manage, you find that people are poor at using their inhalers. They don't understand when to escalate their treatment plan. In the middle of the night, they become frightened, they become breathless, and they think they're going to die. So they call an ambulance and come to hospital. And probably many cases they need good psychological support to manage their condition differently. So in a way, we're trying to find some pretty low-tech solutions, never mind all the beautiful robotic-assisted surgery, which, by the way, we all love, and it's very important. But we're trying to find some low-tech population health solutions to some of these new population health challenges that we're facing. And so our public health department in Liverpool, which is one of the oldest in the world, is trying to make sense of these demographics. And this further rather depressing chart is showing where they think health is going to go in Liverpool in the next 10 or 15 years or so. And of course, sadly, most of it looks like it's going to get worse. PAD is peripheral arterial disease, CHD is coronary heart disease. They're the only two things that the public health team think are going to become less prevalent, and that's down to reduced smoking prevalence. So one of the biggest impacts we can make across the system is to help people to stop smoking. And actually, in young men in the United Kingdom, smoking rates have gone down substantially. Unfortunately, in young women, that is not the case, and that's probably building up a new disease pattern for years to come. And so I'm making, I hope, a reasonably powerful argument around the wider determinants of health, why it's important that we think about them, because in the end, we can't manage all these things as hospitals alone. We need a broader view of how the system functions. And certainly in my own organization, we like to talk about making every consultation count. So every time you interact with a patient, what can you do that helps them in terms of helping them to live their lives better, to be more self-caring, to be thoughtful about their diet and their exercise and smoking and so forth. And we interact with people all the time, don't we? So the opportunities are enormous to engage in that kind of behavior. It also occurs to me, and this is a serious point, if you work in a hospital probably it's true in any population, but let's say it's a relatively deprived population, what you find is that you see people sequentially through their life course. So you'll see them as babies and children in pediatrics. Maybe you'll see the young women coming in antenatal and natal care. You'll see injuries. You'll see early onset diseases and so on. And you'll see people right through their life course. And so it is worthwhile and important, I believe, that hospital organizations think about that. And when you think about medical records, as an example, you think about their potential to build a understanding of a patient through their entire life course. So the design of medical records and how we use them, I think, is very important in that regard. I guess I'm getting to the point where I'm saying the same thing, but I'm trying to draw a difference between the United Kingdom and India, and definitely reassure you that I don't think this is where you are. In India, you have enormous opportunity to grow the economy, to grow provision of healthcare, to help people grow old well, and so on and so forth. In the UK, we're dealing with an issue where we have 7 million. So the population of UK is about 70 million. Population of India, 1.4 billion, I think. And we have about 7 million patients waiting for treatment. So that's 10% of the population. I think most of you would find that maybe shocking, but also you wouldn't tolerate it because the way your services are provided is quite different. So again, we're dealing with a different set of problems now, which are to do with how the system has evolved over time. And I am absolutely clear, because I've worked now in the health service for more than 30 years, let's say, we didn't understand, we didn't appreciate the impact of aging on the system. As a population ages, its impact on healthcare I think grows exponentially. It's pretty hard to predict, other than there are now models from other countries that you can have a look at. We thought that if we invested in more community facilities, social care facilities, we would crack it. But what we found was that as populations change, families are less inclined to look after their aging relatives, and they become more separate, more independent, and they look to the health service to deal with those issues. And we hadn't seen that coming, quite frankly. So I would beg to suggest it might be something you could see coming and think very carefully about. So very, very quickly, we are building our own 5-year strategy in our own organization. And what we're really trying to say in this strategy is we recognize these other challenges. We need to think about being a very different organization to the one that we've been up until this point. We do need to transform our services. We shouldn't be bringing patients to hospital who don't need to come. It's bad use of their time. It's bad use of fuel. It's not good for the population. So we're trying to rethink the way we deliver, and we're recognizing explicitly that we can't do that by ourselves. And broadly, this boils down to 3 groups when it comes to clinical care. You want your hospitals to be as good as they possibly can. And we've probably all got some kind of version in our minds of what that means. They need to be efficient. They need to have great clinicians. They need to give great care. They need to use the latest tech and so on. And they need to minimize length of stay and get people back out into their homes as quickly as possible. There are a lot of people who are using hospital services for some kind of outpatient therapy, to get a diagnosis, to get a treatment plan. And by and large, we don't think those people need to come to hospital at all. We think we can arrange their care in a much more dynamic way. And of course, video consultations and outreach clinics and so on allow us to deliver that. But perhaps more importantly and pertinent to what I'm saying, we recognize the need to engage in neighborhood care. That from the hospital, we need to reach out into communities and upstream our care. An example I've kind of given you is around respiratory care, where we need our respiratory physicians to be out of the hospital managing respiratory disease in the community, whilst at the same time, of course, having the hospital capacity to deal with it when it's needed. And there's tons and tons of evidence that if you improve the management of asthma and COPD in the community, you will reduce hospital admissions. And depends on your funding model, but what I'm really trying to get across is we're not trying to increase the number of people who come to our hospitals now. We are actively trying to decrease that. I've made the point about workforce. I think this is a couple of years old now, but that thing about India needs 3.9 million doctors and nurses, it's something about the scale of the task. So for all of you, I don't think you need to worry about your future employment issues, but it shows that education and training across India and many parts of the world needs to develop, and it's a global industry. So interactions across the globe around medical education are logical and, in my opinion, very desirable as well. And probably the last slide, I think, Si and I were talking about this in the car over, because this is a slide I've taken from McKinsey's, who are a global consultancy. And it's titled The Rise of the Humans, but I think this probably should be titled The Demise of the Humans, because this is about the rise of artificial intelligence and automation. So McKinsey's think that about a third of the activities undertaken by humans at the moment in healthcare could be automated. And I bet you all have examples of where you're starting to see AI have an impact on healthcare. And it depends a bit on your attitude to the world, whether you think that's a good thing or a bad thing. My own view is there is so much work to do. We need to be as efficient as we possibly can be, and AI presents us with extraordinary opportunities to do that. Now, here's something that I found quite shocking. In Liverpool, the average reading age of our citizens is equivalent of a 9-year-old child. So, of course, that's not true of everyone. I think my reading age is marginally better than that. But the point is, we communicate with a group of patients and have to acknowledge that many of them may not have even been able to understand the stuff that we're sending out to them. So we've used artificial intelligence in real time to rewrite the letters that our doctors and nurses and other colleagues are writing, so that when the letters go out, they're going out with a reading age of 9. And that's helped us to really think about our communication strategies with patients and citizens. Of course, I bet you're doing it here. We're getting into AI around diagnostics. We're certainly using AI in skin diagnosis. Malignant melanoma is a big issue in Anglo-Saxons in the UK, and AI is very, very good at wheedling out the potential melanomas from benign lesions. So that's one area that we're actively using. We still have a clinician in that pathway, but colleagues at St George's in London have removed the clinician entirely from their screening pathway now. And we will do that soon once we've done a few more thousand and have got more confident. And then diagnostics is an obvious place to use AI, but in terms of letter writing, communicating with patients, and therefore reducing secretarial burden and so on, the opportunities seem enormous. So it's happening all around the world. We can't ignore it, and actually there are loads and loads of opportunities within it, which I would encourage us all to take up. I think I was trying to do a final closing slide in the car on the way over, but failed to do that. But I think hopefully I've got across a message that hospitals are ace. We need them. You need to be the best you can. I think GEMS is fantastic, but hospitals by themselves are not the solution. The solution exists in a system-wide approach to healthcare, and I have no doubt within the School of Medicine at GEMS, then that notion of Dean of holistic healthcare, thinking about public and population health, is really important. Thank you very much, colleagues.
That's really wonderful, Professor Jim Gardner. But then we really have a lot to discuss about all this. But then because of lack of time, I think I'll just mention about a few points. Regarding emergencies, we do have emergency services 24/7. But it's like how Dr. Hemant was mentioning to you in the morning. Suppose it's a cardiology case and we have good number of volunteers who say that, okay, fine, push them to cardiology immediately. They don't have to go through emergency. Like we have obstetrics separate team, we have neonatology separate team. So then the actual cases that come to emergencies are different because of this is all the work of the people in the public who are helping them, who are guiding them to go to the respective places. That's how emergencies will be taken care of here. And then, as you said, major illness is growing like any other country. At the same time, the working population is also growing. That's what I should say. Maybe the pediatrics age group is coming down, and after some time, maybe we'll find only the geriatrics and the younger population and nothing below that. Let's see how it's going to be. And as you rightly mentioned about the community services, we do have good amount of community service going on. We have so many things in common with you, but then we differ at few places, definitely. But then because of lack of time, we are not able to debate on these points. But then that's a wonderful presentation from your side, and we could really understand very well like how it's going to be. And I think we all have got benefited and what the world is outside India. Thank you so much for your wonderful presentation. Thank you so much. Now at this juncture, I would also like to introduce Dr. Sai Pillarisetti. Please get up once so that Dr. Sai is not new to us. He is our Vice President of Aditya Educational Society, Dr. Raghuram Pillarisetti's son. He is settled in UK. Sit down, Sai. Thank you. So he is the senior leadership team, Great Manchester Medical School and General Secretary, British International Doctors Association. And so he's played a crucial role to get Dr. Jim over here. Thank you, Sai, for all this. And then definitely, I think we'll be in touch and we'll be collaborating and learning good things from you and sharing our good things with you. Thank you so much. So I request Sudhi sir and Dr. Hemant sir to please come onto the desk. Ambedkar sir, run. So, Professor Jim, please come onto the desk. Yeah. Sai, you can join. Please join. No, somebody can click. Please join. No, please, Randy. Please come. Please be here. So I request Professor Jim to please accept. Please sit down. Yeah. Thank you so much for sharing your ideas. Thank you. సాయి ఇక్కడ కూర్చుని ఇంత పొడుగున్నా he's a very he's a kid, I should say, before all of us, but we are very happy that he's with us doing a great job. Thank you, Sai. So because of lack of time, we are unable to, the students are unable to interact with you because you have to start now, time is up. And then, but then I think better luck next time. We'll have, we want to interact with you. So thank you so much for being here. Thank you, Sai. Thank you, thank you, thank you so much. Thank you all for being present.